All right, it's noon now. Well, thank you everybody here in person and on Zoom for taking the time to be with us today. We have a very, very special guest, our very own Dr. Kelly Goode. She kindly accepted our invitation to speak at this CPPI seminar. For those of you who may not be familiar, Dr. Goode is a professor here at the school. She also wears a multiple hats with professional organizations. She has served as president of the American Pharmacists Association, also the Virginia Pharmacists Association. So very involved with everything about pharmacy practice and led the initiatives about immunizations in community pharmacy way back when all of this started to be a service provided by pharmacists. So a very, very a big asset that we have at the school and that we are fortunate to have today speaking at the CPPI seminar. So thank you very much for coming. And without further ado, I will turn it over to you, Dr. Goode.
Good afternoon, everyone. Thanks, Dr. Salgado, for that nice introduction. I'm really excited to be able to be here today to talk about connecting the dots, the past, present, and future of community pharmacy-based innovations. Oops. So for CE, Sydney's going to put the information in the chat for you all to get CE credit for today. Those are those slides for the CE. Today's objectives, we're really going to talk about the history. We're going to talk about some of the things that differentiate the value and role of the pharmacist, as well as some of the innovations current and future, and then scenario planning for our future. So innovation, what is innovation? An easy question, right? Well, maybe, but typically pharmacy has really struggled in sort of making ideas happen, solving problems, implementing new services, and being able to do it profitably, or even being able to justify the outcomes of those services. So in order to really think about innovation, we need to look at our past, our present, and our future. And I think Steve Jobs said it best. He said, you can't connect the dots looking forward, you can only connect them looking backwards. So you have to trust that the dots will somehow connect in your future. So we're going to start our journey by connecting the dots by looking at our past and looking backwards. So our pharmacy timeline, when we think about pharmacy practice, and I'm not sure why those didn't show up, but that's okay. I can sort of walk you through my words are missing in the middle. We have really 4,000 years of pharmacy history, right? And sort of the core of our pharmacist history has been the service. It's been, our motto has been accuracy, and our virtue is really our trustworthiness. And so this is not 4,000 years of an era, but it's really looking at pre-modern era, the soda fountain era, our lick, stick, and pour era, our pharmaceutical care, and our post-pharmaceutical care era. And so as we think about this, as we move through these eras, one of the things that I think is really interesting is what pharmacists have done to ourselves and what we've done in developing our code of ethics for our profession. So if we go way back to 1852, we have in there, very interestingly enough, that the skill, knowledge, and responsibility required in the practice of pharmacy are great. The remuneration of our services should be proportional to these rather than the market value of the preparation rendered. That's almost 150 years ago. We're still fighting these values. Then in 1922, around that sort of soda fountain era, the pharmacist said we shouldn't discuss with our patients what they were getting ready to take and what the physician gave them. So we put that upon ourselves in our code of ethics. And then as we move into where we had more manufactured products, to the health, we moved where health and safety of the patient should be first, and that we were health practitioners. And then moving to 1994, which is really much our current code of ethics today, is that we are the health professionals who assist individuals with making the best use of medications, and that we have to serve society and our communities. So again, I'm not sure why these are not there, but I want to just hit a few highlights. And this is in the soda fountain era, which is in the middle. So in 1932 is when we had our first educational standards. That's when ACPE was created. We had over history, when you look at the timeline, we've had lots of consensus conferences. We've had lots of studies done about pharmacy on what pharmacists should do by people outside of pharmacy. And in Virginia, we have a long history of innovation in pharmacy, especially community-based pharmacy practice. And I want to focus a little bit on that. So if we go back to the 1960s, there was a gentleman named Eugene White, who has since passed away, but he created the office-based family pharmacist. In 1954, he wrote a letter to the Virginia Pharmacist that talked about how the pharmacist should be responsible as the pharmacotherapy specialist. The pharmacist should be responsible for prescribing and should be on that level of the physician as an independent person. And then he was the first person that created the medication profile. And he also rearranged his practice. He got rid of the front end and made it a consultation area, and he only dispensed prescriptions, didn't have all the merchandising. At that time, there was also lots of controversy in pharmacy about how we were going to give up compounding and making the product and moving to manufacturing. And he won the Remington Medal, which is the highest honor a pharmacist can receive. And in that address, he said that we must take the pharmacist out of the store and the store out of pharmacy. And so way back when, we're still talking about some of the same things that we're talking about now. So this gives you a little bit more about the timeline. I just want to highlight a couple other things. The 1984-1989 conference looked at what really declaring pharmacists as a clinical profession. 1989, Hepler and Strand wrote their paper on pharmaceutical care, which sort of guided pharmacists to a different level of patient care. Community pharmacy residency programs were beginning. We had, in the 2000s, Project Impact Hyperlipidemia, APHA founded project that looked at the pharmacist working in conjunction with the physician, helping patients take their medications better, and found almost over 90% adherence and persistence to therapy. So adherence meaning they were taking their medications, persistence meaning that at the end of the year, they were still taking those medications. Previous data to that showed about a 50% adherence rate. They also were shown that patients could get to at that time, we really treated cholesterol to goal levels, that we could get those patients to goal. Also around the same time, the Asheville project was happening in the city of Asheville. And that was where they took employees that had diabetes in the city of Asheville, North Carolina, had them work and do an education class, partner with the community-based pharmacist, and they paid the community-based pharmacist to take care of those patients with diabetes. And what they found in those employees was a $1,200 to $1,800 savings per patient, and they paid the pharmacist, as well as they cut the employees' sick days in half, increasing productivity in the city of Asheville by $1,800 per employee. So we saw lots of growth in showing that the community-based pharmacists could do something. At the same time, in the early 2000s, the Pharmacist Services Technical Advisory Committee was created. That committee has been charged with developing what we now, the MTM codes, which finally passed through the American Medical Association in 2008. We went to the all Pharm.D in 2005. So lots of changes happening in sort of this pharmaceutical care era, leading to sort of where we're going in our present now. So I think we really need to look and be wise enough to learn from the past, shrewd enough to capitalize on the present, and clever enough to prepare for our future. So what does that look? What have we learned? So interestingly enough, I'm not sure we've learned a lot. So when we think about the past and where we are as a pharmacist of being in the drugstore and manipulating the prescription, to what was Don Brody wrote in one of his papers about preventive medicine, wellness, being public health person. And we continue to be at this crossroads. And if you go back to the Remington medalist lectures throughout the years, you'll see almost every one of them talk about how now is pharmacy's time, we're at pharmacy's crossroads. And here we are hundreds of years later in this modern era of being able to try to figure out where we are, what we need to do, and where we need to go. But we have made some progress. So let's talk a little bit about the present and kind of where we are. So pharmacist, what is a pharmacist, right? We still all scratch our head. If I asked everybody in the room, everybody on Zoom to describe what a pharmacist does, it would be something different, right? We talk about our associations, it's something different. And so when we look at that, all of these words talk about what pharmacists do. We have pharmaceutical care. We now have medication therapy management. We have comprehensive medication therapy management, patient education, pharmacotherapy, med rec. So all of these terms, really, what are we, who are we, and what do we do? And we talked about consensus conferences. Well, we've had another consensus conference. Where should we go? What is pharmacy going to look like? And it's really looking at lifelong learning. What should education look like? What should our professional identity be? How do we optimize the postgraduate training? How do we look at continuing professional development? But what's interesting here, when you look at the big title, is that fostering a culture of community. So I really want to talk about then how important that community-based pharmacy practice is. It's where the patients are. It's a front door to our pharmacy practice. When we look at where patients go, 35 times a year to their community-based pharmacy, maybe only 4 times to their physician. When we look at where pharmacies are located, 93% of them are located within 5 miles. Every American's located within 5 miles of a community-based pharmacy. So we need to think about then for our profession, how do we capitalize on that and move forward? Many times when we think about community pharmacy, the profession has been unwilling, even though we are a clinical profession, everyone comes out with the same Pharm.D degree, unwilling to attach that clinical to the community-based pharmacist. And so in 2015, when we looked at trying to predict where community residency training was going to go, we had a vision for what it should look like. And so when we designed that 2017 residency training standard for community-based practice, it really looked at this community-based pharmacist practitioner and what was that person, what did they do within those communities, and how can we train that resident to be this person. So what is that person? It's the pharmacist who routinely provides patient care services within the community. And when we think about that, so it came from this planning committee to look at where the residency standard was going to go. We had a commentary that was written on recognizing these people and what they were doing in their practices. And when we looked at this practitioner term, a practitioner is really someone who's qualified to provide and routinely deliver a certain level of services. And so community pharmacists, we've seen that presently, that they have refined skills, they're stepping up, they're serving their communities and providing healthcare needs to what their communities need. They're out there where patients live, work, play, and pray. And we need to make sure that they're widely recognized for this and the services they're offering. So what is that community? So the community is not just the 4 walls. It's the ambulatory care clinics. It's federally qualified healthcare centers. It's home care. It's being in the employer work sites. It's long-term care. So anywhere that a pharmacist is serving that sort of ambulatory type patient that can walk in and take care of that patient, and also getting out to where those patients are. Maybe the churches. I don't know if anybody's familiar with the barbershop study where they put pharmacists in the barbershops and help manage hypertension. That's the epitome of the community-based pharmacist practitioner who's meeting patients where they are and where they need to be taken care of. So what does this person do? So they're going to create and advance team-based care. They're going to enhance community, so they're designing these services that meet the needs of their patients. They're leaders within their community-based practice settings, leaders in their communities, and leaders in the profession. And then they're providing this direct patient care. And I'm going to talk a little bit more about what we're seeing in those services in a minute. And so how did we do when we think about this was our vision for community-based residency training? Interestingly, the new standard has just been released for residency training, and there's going to be one standard no matter where you train, whether you're in a health system, a community-based pharmacy, or managed care, or even PGY2. There's going to be one standard for residency training that will go in July 1. We're lagging a little bit behind when we look at community-based residency programs versus our other PGY1 types. We're ahead of managed care, but really behind that health system. PGY1 residency program, we have 181 programs, the ability to train about 260 some community-based residents. Some of the issues there are payment. CMS will do pass-through funding in health systems, but they won't do that in a community-based pharmacy. So when we look at these programs, they're funding and paying salaries for residents out of their own dollars to have those residents in those practices. And where are we at VCU? So we've had a community-based residency training program for 25 years. We are producing practice change agents. We have had over 125 resident graduates. They're making contributions to community-based practice scholarship. It's qualitative, quantitative. They're looking at pharmacist services implementation, patient care outcomes, and patient satisfaction. So it's really important when we think about training these residents to do scholarship and best practice and practice-based research, because that's one of our issues in community-based practice is we don't do a very good job documenting not only our taking care of patients, but also our outcomes and what we're doing there and sharing that with the world. So let's look at the models of community-based pharmacies. And so remember, these are the pharmacies that are the sort of the bricks and mortar and what they're doing. So you have this traditional community-based pharmacy in that middle. So that's your bricks and mortar. And what we're seeing is those pharmacies, as I mentioned, being out in the communities. So they're doing community outreach. We saw that a lot in COVID. They stood up COVID vaccine clinics. They stood up testing sites. We're seeing those pharmacists that are in those traditional pharmacies being employed by the pharmacy, but spending some of their time in physician offices taking care of patients. We see some of them that may be employed by the community pharmacy, but totally in that physician practice office, but they're paid by the pharmacy. And then we're seeing these practitioners go to the patient home and take care of patients as well. So as I mentioned, it's no longer about that sort of bricks and mortar, but it's really about how we're building community and how we're meeting the needs of our patients in our communities. And so it's really that healthcare without walls. And so moving forward to really how do we envision what we're going to do, and we're seeing this happen currently. And I'm going to talk a little bit later about the future and where I think we're sort of going to go there. So what are the services that are being offered in these community-based pharmacy practices? So as I mentioned, remember, we scratched the head. What is a pharmacist? What do we do? What terms do we use? And so we wrote a paper trying to sort of think about what are the buckets? What are the things that we're doing? And I think the core still, and we have to stand on this, is we are the medication experts. So what does that look like, and how does that play into all the services that we offer? And so the biggest bucket, and the bucket that's most important really, is probably that medication optimization. So in that bucket are things like adherence packaging, medication therapy management, comprehensive review, home deliveries, medication synchronization, the appointment-based model. So all of those things are in that medication optimization bucket. And then from there, obviously, when we talk about meds, right, education is important. So there's education that happens, obviously, at that medication level. There's education that's happening, diabetes education, diabetes prevention education. There's education happening. Many of these practices may have conference rooms where people can come in and do group education. So we have all types of education that's happening as well. We can also look at wellness and prevention. So many chronic diseases have risk factors that can be sort of modified through wellness and prevention programs. What we're seeing with pharmacists doing there is weight management, immunizations, travel health, naloxone, all kinds of things in sort of that prevention category. Because remember, if I'm trying to lose weight, or if I am trying to be motivated to do something different as a change, and I'm seeing my pharmacist 35 times a year versus my healthcare provider or my physician or nurse practitioner, that's much better for coaching. How are you doing? Wow, we've made that one goal. Let's move forward. Versus if I make a goal in September and I don't do it and carry it out and don't see my provider till again December. The other thing that pharmacists are doing is screening. So they're risk assessment screenings, which can be more about just like falls risk assessment. So it's like a paper-based type screening, as well as point of care testing screening, which leads into that laboratory. So I could screen you for diabetes. I could screen you for HIV. And then that moves into this sort of laboratory testing bucket. And so we're seeing pharmacies become CLIA wave laboratories, because as our technology gets better for point of care testing or that bedside machine, pharmacists can use that. They're CLIA waived. They don't have to meet all the laboratory testing criteria of having a medical director and doing quality testing and sending it to the lab for comparing samples. But so what we're seeing in laboratory testing is something that sort of emerged as test and treat. So you can go to a community-based pharmacy and be tested for influenza and then get treated right there without having to wait to go to the primary care doctor or go to an urgent care center. They're doing that for strep. They're doing it for also HIV, PEP, and PrEP. So exposure to HIV, we can do post-exposure prophylaxis as well as prevention. And then monitoring. So community-based pharmacies have anticoagulation clinics. They have they can do A1C. So all of this is part of what's happening in community-based pharmacies. And then our last sort of bucket is all the other stuff, right? And there's so much more that we can do, but that's where our chronic care disease management is happening. That's DME, that's some of the nutraceuticals. So a lot of things going on in sort of that other patient care bucket. So then how do we get there? How to have these services come about, and what do we need to think about in the present to get there better? So there's sort of three buckets that we need to look at in the profession. The first is provider designation. The second is payment for service, and Practice Act. The third is Practice Act optimization. So I think it's important to understand the differences in these. A lot of people misuse these. So that provider designation, what that does is if you look at the Medicare Social Security Act in this country and you read the definition of a healthcare provider, the pharmacist is not there. We're not listed. A midwife is listed, but not the pharmacist. So we're trying to open up that Social Security Act and insert that pharmacist in that list. And the reason that's important is because as the government payer, the gold standard payer, Medicare won't pay because pharmacists are not listed there. So that's important at that federal level. And then why it's important at the federal level is because, as I said, it's the gold standard. So that means that other payers typically will follow what Medicare will pay. And then at the state, you don't have to follow Medicare. Private insurances, commercial insurances can do what they want. So if you have provider status at that state level, then that might mean payment for you at the state level. At the federal level, we have two bills that are there. The Equitable Access, Community Access is the bill to look at that PrEP Act and codify that in federal law that we're allowed to do under the Federal PrEP Act for COVID, but wouldn't be allowed to do once that PrEP Act goes away. And then the Pharmacy and Medical Underserved Areas Enhancement Act is looking at where it's open, that's the opening up of the Social Security Act and inserting pharmacists to provide care in these medically underserved areas. And this bill has been in several iterations, and we've started this process in 2015. So we're continuing to do this every year. And again, when we talk about it, it's not about the money. Even when it's not about the money, it's about the money. Part of this is about the money because they have to score the cost of this. And when they look at all pharmacists everywhere, the cost can be astronomical. So in Virginia, we're healthcare providers. We've been considered healthcare providers for 20 years. Unfortunately, that doesn't mean Medicaid is recognizing us. So new legislation this year will require Medicaid to recognize pharmacists for payment for services that is in the pharmacist's scope. But so it's not going to add new services, but if they pay another healthcare professional for that same service, they're going to have to pay the pharmacist if we're able to get this through. So then what's scope of practice? Scope of practice says what I can do as a pharmacist under my pharmacy license. And so when we look at that, remember I talked about Eugene White in 1950 talking about the pharmacist prescribing? Well, here we are today in 2023, still working on this. But there's several different ways pharmacists can do that. Collaborative prescribing under a collaborative practice agreement. It could be individual to patient pharmacist provider, or it could be population specific, such as a group of diabetes patients. And then this autonomous prescribing is really, we're seeing a lot under statewide protocols. So if I'm a pharmacist and I meet the criteria, then I can prescribe that medication as long as I follow what it says I need to do. And then unrestricted, Idaho as a state has the best sort of practice act for unrestricted prescribing. They don't have to go back to the legislature every single time they want to be able to do something new. They have a committee that can grant pharmacists that authority. So that federal PrEP Act, what does it say we can do? So that's the COVID testing, that's the childhood vaccines, COVID vaccines, influenza vaccines. It allows pharmacy technicians and interns to administer. And it also allows pharmacists to prescribe Paxlovid. So when that goes away, though, then all of these, if the states aren't at that same level, all of this will go away. And why is that important? I want to just share what we sort of know, some of the services I've talked about and where we are in the country. So we think about immunizations. We've been doing immunizations since 1996, but still pharmacists do not have autonomous prescribing of vaccines. So you can look across here. So the state is not, all of them are not blue, dark blue, which would mean that as a pharmacist, you come into my pharmacy. As long as that vaccine is on that CDC schedule, I can go ahead and prescribe it and administer it. Even worse when we look at this sort of 7 to 18 years of age and whether we can do all vaccines or not. So this is not autonomous prescribing. This is just whether or not we can administer the vaccines. And then when we look at less than 7 years of age, remember the PrEP Act has given us authority 3 and above. However, when that goes away, that means a lot of these states are going to lose the ability for pharmacists to do that. And then, so I'm going to talk a little bit in a minute about this pharmacist support team and what we need to make some of this happen. And so technician vaccine authority is also there, but not very widespread, but it's under the PrEP Act, right? So when the PrEP Act goes away, that's going to go away. And as we move to expand services, we need that patient care support person to help the pharmacist be able to do all the things we want to do. And then I mentioned that test and treat and where we are with CLIA waived pharmacies. So you can see most states, more than 45% of pharmacies in the state has a CLIA waiver. And we saw that with COVID testing increase. So since 2020, 14,000 pharmacies have gotten a CLIA waiver. If you look back in the 90s, those early innovators, grocery store chains, independents, were doing that point of care testing, the cholesterol testing, the blood sugar testing. And that sort of waned, not as much, need for those types of testings in community pharmacy, but now we're moving into the test and treat and some of the other activities. So who has test and treat? So very limited. 6 states have the ability to do test and treat specifically. There are 22 others that might be able to do it under sort of their Collaborative Practice Act. Virginia does not have the authority to do test and treat. We have legislation in now to allow pharmacists to do test and treat for strep, UTIs, influenza, COVID, and those 4 that are in there now. HIV, PEP, and PrEP. Virginia has this authority, but again, not as many to expand access to those life-saving medications and prevention medications from HIV. And then hormonal contraceptives, 22 states, pharmacists are allowed to prescribe hormonal contraceptives. So if you're a female and want to come in and get your refill or get a new hormonal contraceptive, you can do that in the pharmacies. Most of these are typically the oral or self-administered, so definitely not more the long-acting hormonal contraceptives, but this is something that is needed, especially in the Medicaid population and people who may not have access to health care like other people. Tobacco cessation aids. This is state is a little bit maps a little bit out of date. This was the March 2022. Virginia just got the authority for tobacco cessation, and let me ground you a little bit here. So the green is would be all products, tobacco cessation products. The sort of the brownish color is just nicotine products, and then the yellow is the nicotine product, the nicotine OTC products. So we have nicotine products that are not OTC, and so not all pharmacists can prescribe. If you want a cartridge or a nasal spray, a pharmacist couldn't prescribe that. They can only do the OTC. So let's look at the Commonwealth of Virginia and where we are. We've had some pretty good years the last few years. We have a new dynamic director of the association, and her skill is legislative activities, and it shows. So in 2020, pharmacists got a standing protocol for naloxone, epinephrine, the contraceptives, prenatal vitamins. And then how many times have you gone into a pharmacy and you feel like you have allergies and you want to get some Zyrtec, and it's $25 for that little bottle of Zyrtec, but if you had it as a prescription, you could get it for your $4 copay or your $10 copay. And so now pharmacists can help you do that. So they could write the prescription for the Zyrtec and bill your insurance and lower your cost out of pocket for that OTC product. 2021, we got the vaccines. So that now means pharmacists can do it without that statewide protocol. I mean, that protocol that goes through the Board of Nursing. TB skin testing, PrEP and PEP for HIV. And then when we did the prescription legislation in 2020, the Attorney General said that blood glucose meters weren't really covered. And so we had to go back again and ask for those devices, such as blood glucose meters, syringes, things, pen needles, for pharmacists to be able to write for those. 2022, we got vaccines 3 and older, COVID-19 testing, and that was important because when the PrEP Act goes away, pharmacists won't be able to do COVID testing, and then the tobacco cessation products. And as I mentioned, this year we're going after test and treat. That bill continues to sliding through at very narrow margins. So if you have a delegate, please make sure you reach out to them and ask them to support that. So then what have we done? We've looked at the PrEP Act and looked at, you know, what did pharmacists do in this COVID-19 pandemic? If you recall back, and I know it's a little bit hard to remember back then, and we get dates confused around the COVID-19 pandemic. But if you think everybody was home, right? But the pharmacist and the pharmacy staff. And so physician offices didn't take people in. They did telemedicine. The pharmacy was open. So John Grabenstein just published an article this fall looking at what was our role in the COVID-19 pandemic and what did we do? So if you look at COVID-19 vaccines, 270 million. Out almost half of what was given. So pharmacists are really the reason why we're sitting here today, and many of us not masked, right? And then when we look at the who led the program, 50% were pharmacist-led programs. In our practice, we led pharmacists led it, even though it wasn't a pharmacy giving the vaccines. 42 million patient specimens for COVID-19 testing, 100,000 when we were doing monoclonal antibody treatments were provided by pharmacists. And when you take that to lives saved, it averted 1 million deaths, 8 million hospitalizations, saving $450 billion in healthcare. So do pharmacists have an impact? Of course. And so we need to continue to make that message known and share that. So now let's move to that third bubble, payment for service. And we could spend a couple lectures today on payment for service, how you get there, what you do, but I don't really have time for that. So I'm just going to hit the highlights. There's lots of pockets of service payment. Medicaid's paying in some states. Virginia's got some payers that are paying, but it's hard fought. Pharmacists have got to, in the present, we know a little bit, but we don't understand enough about credentialing. So pharmacists are going to have to be credentialed. Currently, payers that pay for prescriptions only know how to credential the pharmacist. So when we went to talk about all these new services with the payers in Virginia, they're like, we don't know how to do the credential of a pharmacist. And so we need to move from that pharmacy building being the place of care to the pharmacist. We might have to have accreditation of community-based pharmacies. There was a community pharmacy, and there still is accreditation, but it was way ahead of its time. So it was expensive, it was onerous, and really no payment for being accredited. So I don't know whether we'll see that resurface. And then quality measures. We hear a lot about pharmacists talking about, I'm measured on what I do and practice. Well, that's going to, if we want to get paid for our service, that's part of it. Physicians get measured on how well they take care of patients. They get measured on the numbers of patients they see. So we're going to have to understand what that means and how we translate that to pharmacy practice. So I want to spend a little bit of time talking about CPSN. And so if you've not heard about it, it's the Community Pharmacy Enhanced Services Network. And it was really built as a way to put pharmacists together to help them provide services and potentially get paid. So I'll put it in perspective. Let's say in Virginia, we wanted to get paid for diabetes care. And I approach Anthem, and I'm one pharmacy in Richmond. Approach Anthem and I tell them all these great things I can do for their patients with diabetes. And Anthem looks at me and says, will you cover about maybe 2,000 of my lives covered? I cover 2-3 million lives. So that one pharmacy, Anthem's not willing to pay that pharmacy to take care of patients when they can't offer that to their whole 2 million lives covered. So this was created to do that, to have pharmacies that were providing higher services than other pharmacies. You have to meet certain criteria. It grew out of a CMS Innovation Center grant out of North Carolina. So it started in North Carolina. They already had a pretty strong clinically integrated network of physicians, and they hooked the pharmacist in with those physicians and were able to sort of create this network and have pharmacists provide care and show some savings. So this has become sort of much more national. So CPS in USA, there are 49 local networks in states in 44 states. And they've created this clinically integrated network to help do this and bring the numbers of pharmacies to be able to pay, right? And so show that they can cover the lives. One of the things that this is Kelly Goode's perspective is that this is a great first step. But what I see as an issue going forward and how we want to build the pharmacist is that the pharmacy is the network, is the entity that is part of the network, not the pharmacist. If you look at physician clinically integrated network, it's the provider that's the person who's part of the network. So we've got to look at pharmacy again. How do we get the pharmacist engaged? But they're doing great things. They have a good model of care where they can screen patients, they can use that patient care process to take care of patients, they can do the follow-up, they're doing program quality, and then they can feed the information back to that payer for what they're doing in sort of performance for that. So when we look at Flip the Pharmacy as a way to get there, they created something called Flip the Pharmacy. And that was really looking at how do we move from just a prescription mill to taking care of patients within our workflows. I mentioned we're not good at documenting. So they wanted to teach pharmacists how to document, how to take care of patients. So we're in Virginia, we have the School of Pharmacy worked with some of the first Flip the Pharmacy people in their practices to help with workflow, patient care process, and then that business model of billing and being able to submit the care plans that they are taking care of patients. So there are 6 domains, and they apply that to opioids, hypertension, and some other areas. So what have they done? 135 million e-care plans submitted, blood pressure readings, e-care plans have SNOMED code. So what it's doing is taking that patient care documentation of the pharmacist and tying it to what medicine does, right? So when your physician goes in the EHR and documents what they did for you today, they listen to your heart, they look at your feet, that all is tied on the back end to something called a SNOMED code, which tells the payer that they actually did the things they needed to do to get paid for what they're billing for. And so this is aligned pharmacy with being able to do that. So if we look at the numbers, they've got 177 payer contracts and potential $14 million in revenue for the pharmacies that are participating in CPSN. Virginia, we have 66 pharmacies that are part of the network. We're on our 5th cohort of Flip the Pharmacy. So we're making progress with some limited payment opportunities for pharmacists in Virginia. So now let's look at the future. So when we think about where we're going in the future, I think Sir Richard Branson kind of said it best. And he said, A plus B plus C plus D. Always be connecting the dots. And it's really important because what it's about is not always creating new, but really taking what we know and seeing what we have and shaping that and creating that in new and interesting ways. And as I mentioned before, pharmacists, we don't really connect the dots, we collect them, right? So we look at what's new, how much more training should I have? How can I put this in there? What's going on? Instead of taking what we know about healthcare and where we are and shaping that to where we need to go. So let's look at some things we need to think about to shape our future. Healthcare is expensive. 2020, we don't have the data for where we are now, it increased almost 10%. $14 trillion in healthcare. Pharmacies, a piece of that, 8%. Pharmacies getting more expensive, right? More targeted drugs, more expensive drugs. So how can pharmacists look at that and what can we do to help that? The other thing we need to think about is chronic disease in this country is just exponentially increasing. What do we use to treat chronic disease? Medications. Who is the person responsible for medications? The pharmacist, right? So we need to think about that. 75 cents out of every dollar and healthcare expenditures goes to treating a chronic disease. The other thing is that there's this whole piece I mentioned before about risk factors and modifiable risk factors that the pharmacist can also have an impact on. So maybe we can also not only treat the disease we have, but prevent the disease. The other thing is medication adherence, $300 billion problem. Pharmacists need to own this space and work to help make sure that if patients are on medications, they're taking that. And that's 13% of our healthcare spending. So look at the impact pharmacists can make there. The other thing is the primary care shortage, right? We know physicians are going to have a shortage of primary care providers. Pharmacists can help step into this role. Physician, when we think about pharmacy practice right now and sort of the mess, some of the things that are happening and where market forces are, primary care is in that same mess and market force. So you can't get a primary care appointment for 6 months. So let's look at the future. So if Jim Rohn says if we don't design our pharmacy plan, chances are we're going to fall into somebody else's plan, right? And what do you think they have planned for pharmacy? Nothing, right? They're not going to help us. So we got to look at the scenario planning and kind of look at this art of the long view. And I've done this a little bit for us today, but it takes a lot more time, a lot bigger brains than I have. But it's really an organized way for us to envision our own future. So it's really organizing your perceptions about that future environment. It's not about predicting the future and saying, or looking at all the different scenarios and saying, we're going to work towards this scenario. It's about knowing all the different scenarios and what are the things that might impact each scenario and how do we plan for those things versus how do we plan to get to that future. And there's lots of key forces, driving forces that impact that. And then you have sort of the scenario logistics that you're looking at. So I picked some key drivers that are, I think, important. I'm going to mention these briefly, and then we're going to talk about where I think some of the scenarios could look like. So social aging population, we have savvy and informed patients. Google is the doctor, right? They know everything. They come in. We have a pharmacist workforce that potentially could be decreased, maybe doing different things. What does the pharmacist workforce look like? We have the digital age, so people have the ability. We have AI. I don't know if you saw the headlines. An AI took the medical school boards and passed, right? So they were able to take medicines boards and pass. So what does that mean for us? New practice technology, new apps for adherence, new specialty medications, targeted therapy, pharmacogenomics. We're looking at new payment models. How is that going to affect us? Quality measures. Uninsured insurance costs in this country is astronomical. My daughter just aged out of our insurance plan, and looking at the marketplace for her, I was just astounded how expensive and the lack of coverage that you got even at that cost. Education, what are we doing to train our pharmacists to get them there? What are the outcomes and satisfaction of quality, not only within pharmacy, but in healthcare? And then political, this scope of practice issues, and for Virginia in our pharmacist bills, the physicians are coming out against it, nurse practitioners against it. So there's all this scope and turf battles, but really if you keep what's best for the patient in mind is always the best. So if you like the Beatles, I came up with sort of 4 scenarios to kind of talk about where I think we're going to go. So if you look here, we have payment for services, payment for product, individual care, team-based care. So let's start here at this 8 days a week. And that's really where our infrastructure, nothing really changes, right? We're getting paid for product. We're the pharmacist in the pharmacy. We're not really connected to anybody else. They sort of don't remember about us. And we're just focused doing sort of the same thing. And so there's not a lot of payment, right? We know product payment is going down. So we're continuing to grind out prescriptions to get more money because that's how we get paid. And if we move up to this hard day's night, now the other thing I want to make sure though is that people understand that when pharmacists are dispensing prescriptions, they are making clinical judgments and getting paid. The issue there is that we don't get enough payment for that product, for that clinical piece. And that ties way back to, when we talked about that soda fountain era, right? When we went from compounding to manufactured products and dispensing, the pharmacist didn't ask for enough money, right, to pay for that knowledge. So that's where we are there, but they're still doing those things. In this hard day's night, We're still individual. We might not have real connectivity still. We are getting some payment for services. So we're a little bit here now, right? So pharmacists are having to do more and more in that practice. They're getting paid for product, but they're doing vaccines, they're doing COVID testing, they're doing all these things that are there with a little bit of payment, but it's not enough to sustain, and they still got to do the other. This all together now is this team-based care. So now I might be connected as part of the team, but I'm still just responsible for that product and really only getting paid for that product. So I don't really have any new things. I'm not doing much patient care services there. And then we can go to sort of this revolution. So that's the overhaul. That's the connectivity. That's access to the EMR. I'm part of the team. I'm getting paid mostly for when I'm doing services. And I'm still sort of responsible for that product. Or maybe I have a patient care support person who's really doing the product, right? And not the pharmacist. And so that's sort of the overhaul of the payment, that's overhaul of connectivity, and overhaul of the pharmacist practice. So this just summarizes that. So you can see no change, some change, product, service here, product, some product, service. And so when you think about that, then we look at all the different driving forces that go to that, right? And where we are in that, and what do we need to think about for when each of these sort of scenarios happens. So if you have a patient that comes in with diabetes, she's on Lantus, she's on metformin, what does her experience look like in each of those scenarios within that pharmacy? So what do I think needs to happen for continued solutions? There's a lot. I could probably go a couple more hours on where I think we need to go, but I'm going to try to summarize it for you. I think education is going to be critical, right? How are we going to train future practitioners, and what does that look like? And do we have the right model? I'm not sure we have the right model. Do we need 4 years postgraduate? I don't know. I have a daughter who was looking at a career in healthcare, and she didn't want to do all that time, right? So it's what do we need to teach student pharmacists? What do we need to do in this value and role of the pharmacist? So that provider status, that payment for service, and then our scope, right? So in order to get where we want to go, I think that every patient in this country, as a medication expert, should have a primary care pharmacist. We've got to get there. The pharmacist has got to be part of that team. In order to do that, we've got some issues with referral processes, especially if we have the scenario where the pharmacist is still that individual, maybe not as connected. And then we've got to capitalize on our support staff, our pharmacy technicians, and what can they do for us? When you go to a physician office, who takes your blood sugar? It's the medical assistant or the nurse, not the physician. Physicians don't know how to give shots. I taught our physicians we went to COVID vaccines, how to give an IM injection. We taught the whole campus, right? We had some of the preeminent physicians at VCU Health come learn how to give an IM injection. So they don't know how to do that, right? So how can we do that and do support? We need to think about technology, AI. How do we get connected? How do our patients are connected? How do we help them? And to do this, we need to concentrate really on, pharmacy, stepping out of pharmacy, knowing what's going on in the world. Sometimes we're in our own little pharmacy bubble. We need to develop people who are advocates. They have to be advocates for the profession. They have to be advocates for their patients and their communities. They have to be leaders. They have to lead from where they stand. In her Remington address, Mary Louise Anderson said, we need to be in between the no longer and the not yet, and have leaders to get us from the no longer to where we need to go in the not yet. We need those types of leaders. We need to train them there. They need to be change agents. So not necessarily entrepreneurs. Many of the early innovators will tell you they didn't want to be merchants. They didn't want to be merchandisers. They want to be innovators, not entrepreneurs. Typically, entrepreneurs means making money, and they really wanted to keep the patient at that forefront of where they are. So to summarize, to build this community of care, change is happening, care delivery, payment, health IT is all coming. So we've got to really be able to think about how that fits in the scenarios, how we deal with those. There's so many unmet patient needs in the community. How do we help solve that? How can we be the solution? We've got to invest in this innovation. We've got to be able to have if we're going to be individual, have that referral system. How many times do we refer to the pharmacy? I say, go do something, the pharmacy, but we never get anything back. The pharmacist doesn't know I've sent the patient. We've got to have that same piece as they do for specialists. We've got to have networks of clinically integrated pharmacists, not necessarily pharmacies. Relationships are going to get us there, right? The relationships that I make one-on-one with the healthcare providers that are in my area, the patients that I have relationships with are all important to help build this community of care. And then recognition of the community-based pharmacists as part of our pharmacy community. And so I spent a lot of time looking, and I think if you have a chance, go back and read some of the Remington addresses. It's fascinating to see sort of how far we've come and how far we really haven't come. But in the third Remington medalist in 1922 said some of these same things. So first he said, pharmacists need to stick together. Second, he said, pharmacy needs to invest in pharmacy, that we need to let the public know about our achievements in pharmacy. We need to invest in more pharmacy research, pharmacist-owned research, and we need to make sure that we help and advocate and be part of our associations. So that's really what all of this summarizes and about, and that was said in 1922. So when you think about, again, connecting the dots from where we are, from our past to our present and our future, we need to think about that and how we can take what we have and shape that for the future. And really, it's because we want the revolution, right? We want that overhaul of our practice. And the power of community to create health is far greater than any physician, clinic, or hospital. And that's how we make a difference with our patients. Thank you all for your time. Oh, I do have assessment questions, so I don't know. Do you want me to do these? Okay, so which of the following, I can't read it because it's on my thing. Which of the following, let me move that. Let's close that. Was an early community-based pharmacist service innovation? Compounding, office-based pharmacy, medication therapy management, pharmacogenomics. So B, office-based pharmacy, right? Eugene White. Which of the following terms pertains to the recognition of pharmacists as healthcare providers? Provider status, scope of practice, payment for service, or credentialing? So the chats are there. So this is your provider status, right? Which of the following community-based pharmacy practice innovations requires a CLIA wave laboratory, immunizations, blood pressure monitoring, test and treat, and falls risk assessment? Test and treat, yep. And then the purpose of scenario planning is to predict the future, choose the preferred future, order perceptions about the future, plan towards the preferred future. So this is that order perceptions about the future. And that's all I have. There's your credit. I'll take questions. I guess we have a little bit of time. Anybody have questions?
There's a little microphone.
Okay.
Hi there. So the governing body, let's see, the AMA is a very powerful force that pushes back against a lot of the work that we try to pitch and trying to move into the getting bills passed. It kind of seems like we have numerous governing bodies that are all working on their own, and they sometimes work as a team. What is your thoughts, I guess, on ways that our profession can kind of move forward to get some more of these bills passed when it seems like we don't have that one leader that kind of leads that charge?
So that's a great question. So you're right. It's fragmented. Healthcare associations are fragmented medicine. They all have different specialty organizations. AMA is sort of the governing. It really starts with those relationships first and foremost, right? So going and building relationships prior to sort of making that ask. And the national associations have done that. AMA is not coming out against provider status for pharmacists. It's really all about the money and the cost of what it could potentially cost Medicare. In Virginia, we did a lot of work behind the scenes with MSV. So MSV stood down They didn't endorse our bill, but they didn't oppose it. But then we had some other physician groups kind of pop up. So it's really about, and we didn't start the relationships with them. So you need to do that before it shows up. And building those relationships. It also comes with building relationships in your community, right? So who's best to speak about the fact that I need Dr. Smith, my pharmacist, to take care of me in my community pharmacy in rural Virginia? Those patients to tell their delegate that's there that they need that pharmacist and they need that service. Because it's really more about what's it for, that when we look at laws, it's that person and what they represent in their community and what their community wants, right? They're there representing us as community people. And so they don't really care per se that a pharmacist gets paid or a pharmacist gets to expand their scope, but they do care that I have a mother in my district that had to drive 2 hours to get a flu test and she was sick and didn't have anybody take care of her children, right? So they do care about that. And so that's how you do it. But it takes a lot of work. It takes a lot of people, a lot of manpower. It's going to take it takes all pharmacists, but we don't have all pharmacists who are engaged and willing to do it, right? Our association memberships across the board, state, national, is terrible. People they don't pay their dues. They don't want to be engaged, but yet they're sometimes one of the first ones to complain about how their practice is in practice. Not everybody, but that's, part of it. So it's about, again, pharmacy taking care of pharmacy, pharmacy sticking together and getting the work done.
If anybody on Zoom has questions too, feel free to write them in the chat and I could translate them over here. Yeah. If not, I have put the CE information in the chat. I was receiving some feedback that there was some issues on the other line. So if you guys are having issues with that, please feel free to reach out with me. Email me. My email is also in the chat. I'll leave that up for a little bit. And I will contact with them and try to resolve that issue and get you guys all the information. Yeah. Thank you so much, Dr. Goode.
Thanks everybody for being here today. Appreciate it.